Dr. Dan Krasalik again from Vascular Institute Chattanooga. So we'll be moving on to PAD syndromes. A lot of the risk factors that we see that are associated with peripheral vascular disease and critical limb ischemia can also be associated with other abnormalities that we take care of as vascular surgeons, such as Crod disease, aneurysms, and then issues with the mesenteric vessels as well. So our next run-up will be looking at atherosclerotic disease and stroke, and then looking at newer options for stroke prevention. That talk will be done by myself. The following talk will be modern care for aneurysmal disease, presented by Dr. William Harris. The next talk after that will be mesenteric insufficiency, the signs, the symptoms, and treatments by Dr. Elizabeth Hartman. And then to finish up this segment, Dr. Chris Lassaro will be talking about renal vascular hypertension and management strategies. Again, if you have any questions during any of these presentations, we'd be happy to answer them. Just place them in the chat and we'll get to them as soon as possible. And we'll go ahead and move on to this next session. Thanks again for being with us today.
Hi, I'm Dr. Dan Krasalik, a vascular surgeon at Vascular Institute Chattanooga. I'll be talking about carotid disease, namely TCAR, a new option for stroke prevention. So stroke remains the fifth leading cause of death in the United States, the leading cause of serious long-term disability. Almost 1 million people are affected each year, and it's predicted that it costs the healthcare system taking care of stroke patients $20 billion per year. Anywhere from 8 to 20% of strokes are caused by carotid artery stenosis or occlusive plaque present in there within the carotid artery. Atherosclerosis does increase with age. 75% of men and 62% of women over age 65 have some sort of atherosclerotic disease in the carotid. When evaluating a patient for possible TIA or stroke, the BFAST is a good way to evaluate. Is their balance off? Are they having signs of amaurosis fugax or signs of a shade coming down over the eyes, unilateral facial droop, weakness on one side of the body, slurred speech, and then of course time is of the essence. Time equals brain when evaluating these patients. First, to work up after you're suspicious for possibly symptomatic lesion is ultrasound criteria. We look at peak systolic velocities and diastolic velocities, and then the ratio between the velocities and the internal compared to the common carotid artery to make a prediction of the degree of stenosis, and that comes into play when determining best treatment modality. The clinical trials that we base most of our management styles off were done in the 1990s. The two bigger symptomatic trials were the North American Symptomatic Carotid Artery Endarterectomy Trial, or NASIT, or the European Carotid Surgery Trial. Some of the limitations of these studies done in the early 90s is that this was in the pre-statin era. Most patients were not on statins, and use of antiplatelet medications and tight control of hypertension were not widely employed. So NASIT basically demonstrated that patients with anywhere from 50% stenosis or higher, when placed on best medical therapy or best medical therapy versus carotid, saw a overall risk of stroke both at 2 and 5 years. This was confirmed with the European symptomatic study that showed a decrease in stroke in 3 years of those that underwent surgery compared to best medical therapy at that time. Symptomatic trials did demonstrate that patients with 50% or less stenosis did not see a significant benefit for surgery, and best medical therapy should be employed for these patients. The asymptomatic trials also showed a similar finding for greater than 60% stenosis, that carotid endarterectomy for these asymptomatic people with high degrees of stenosis showed a lower stroke rate over a 5-year period compared to those randomized to best medical therapy at that time. So the two leading ways to treat carotid disease, one is transfemoral carotid artery stenting. It's been around for about 15 years, makes up almost 20% of procedures done for carotid artery disease. CREST trial, which was published in 2010, namely looked at carotid artery stenting versus endarterectomy, and they found that transfemoral stenting had twice the perioperative stroke risk compared to traditional endarterectomy. And most of that can be contributed to needing to navigate the aortic arch that tends to have atherosclerotic disease in conjunction with the atherosclerotic disease in the carotid artery, and then also needing to traverse the stenosis in the carotid artery to employ distal embolic protection or a filter before doing intervention. Carotid endarterectomy is gold standard. It's the primary way that we take care of lesions that meet criteria. They have low stroke rates. Overall, 2% seen in CREST. However, there is high levels of cranial nerve injury that's unresolved, 2%, and also higher levels of MI seen in the perioperative period compared to those with transfemoral stenting that was done in the CREST trial. When do we operate after a stroke? Historically, we would wait weeks to months due to concern for hemorrhagic conversion. NASCET kind of showed us that risk is a lot of times not necessarily true, with a low risk of hemorrhagic conversion in the early stage. Current guidelines is to perform carotid revascularization on a symptomatic severe lesion within 2 weeks of their inciting event, as long as they don't have a permanent disability or a major deficit from their stroke and they've recovered. Management of comorbidities is key for these patients, whether they're receiving surgery or not. Antiplatelet therapy, either with a single or dual agents, has been shown both to reduce the stroke rate after surgery and also major adverse cardiac events. Antihypertensive therapy, controlling blood pressures to acceptable ranges, is also very important. Control their diabetes, smoking cessation, and then statin therapy, reducing the LDL by at least 50% or less than 70 is a key, both pre and post intervention. So surgical intervention for all symptomatic stenosis greater than 50%. Surgical intervention currently based on SVS guidelines for high-grade stenosis greater than 70% in asymptomatic patients, and transfemoral carotid artery stenting in select patients that would be deemed high surgical risk for open operation. So carotid endarterectomy, like I said, gold standard, one of the most commonly performed major vascular cases in the US. This is how we perform it. Larger incision in the neck, carotid artery is dissected out. You can see the carotid artery here, jugular vein, vagus nerve runs along there, hypoglossal, which controls the tongue, runs kind of right under the angle of the mandible. You open the artery here and then remove the plaque and then put a patch on it. This is just an angiogram showing the lesion with the plaque removed. Transfemoral stenting, 20% about interventions for carotid traditionally. Like I said before, have to traverse the aortic arch that tends to have a high degree of atherosclerosis, and then also get across the lesion and deploy a filter or embolic protection device. All those steps are at risk for causing debris to break off and travel up into the brain, leading to a stroke. So where does TCAR come in? TCAR stands for transcarotid arterial revascularization. It employs direct carotid access with reversal of flow for delivery of a carotid stent. So a small incision is made in the neck, accessing the femoral vein in the groin. The artery is clamped, and the high pressure arterial system causes flow reversal from the carotid artery through this filter device here and back to the vein, with the filter being present there. So when you do cross this lesion, you're reversing flow, so any debris that does break off cannot travel to the brain. It's brought back into the sheath and then filtered and captured here with blood returning. Criteria for TCAR, a lot of it is age or comorbidities. Age greater than 75 all meet criteria for CMS for coverage for this. But people with significant heart disease, previous MI, abnormal stress tests, they need to have another major surgical intervention. They have uncontrolled diabetes or bad lungs. That meets criteria. And then there's also several criteria for anatomic reasons why a open operation would be less than ideal compared to a small incision just above the clavicle. So within the first Roadster trial, which was kind of the first major kind of clinical trial within this, performed by experts, the stroke rate was 1.4% in high-risk surgical patients. In CREST, carotid artery endarterectomy, stroke risk was 2.3, and then transfemoral was 4.1. So you can see a much lower risk of stroke, although the numbers within the treatment population is rather low in this compared to the CREST trial. Roadster 2, which is the study for wide release of TCAR, showed an actual lower rate of perioperative stroke within these patients. And this is for kind of all comers that go through initial training in TCAR and then are allowed to perform the procedure, showing much lower stroke rates compared to endarterectomy and transfemoral stenting, just showing it's a safe procedure in these high-risk patients. Lower rates of MI is seen in the perioperative period, and no significant unresolved cranial nerve injuries have been reported in any of the major trials, and that's just due to the location of the incision that's made down in the clavicle. You're staying out of this high-value real estate up in the neck where a lot of the cranial nerves traverse through. Multi-institutional study looking at TCAR versus endarterectomy within a single institution tended to be sicker patients with equivocal outcomes, both with stroke and MI performed on these patients, just showing that TCAR is as safe as endarterectomy in high-risk patients. And then another concern is you're putting a stent instead of actually performing endarterectomy and removing the disease, but several studies have shown that once you get out of the perioperative period, that stents in the carotid artery tend to last and be patent just as long as the endarterectomy treated segments are. This is just an example of the procedure. This is the incision just above the clavicle here. The carotid artery is there. You get the sheath put in place. This is my case. Angiogram is taken. You can see the tight stenosis represented by the red arrow, and then post stent placement with good luminal expansion. And you see the scar right there, just kind of over the clavicle area. This is some representation of what the filter captures within these cases. This all, if traveled up to the brain, would result in significant stroke with probably permanent deficits in these patients. So in summary, TCAR is a safe and effective treatment for patients with carotid artery stenosis. Outcomes in the Roadster and Roadster 2 trial show that even in patients deemed high risk for surgical intervention, that they have low rates for stroke, and this can be performed for patients with symptomatic disease and older age. And outcomes with TCAR are consistent across all physicians with various degrees of experience, showing that the technology that's available through this, if employed correctly, shows very low stroke rates, making it a safe procedure for those high-risk patients.
Hello again, I'm Will Harris. I'm one of the surgeons at Vascular Institute of Chattanooga. We'd like to talk briefly about the modern management of abdominal aortic aneurysms. Well, aortic aneurysms as a whole. I don't have anything disclosed. This is a CT cross-sectional image of an aortic aneurysm that measures, as you can see, the aneurysm itself is about 5.7 centimeters, 5.8 centimeters maximal diameter. This is a non-contrasted CT, so you can see the rim of calcium. It looks like this may have been a ruptured aneurysm. I can't quite tell. But we'll start off with a case presentation. I think this is a good way to go over this. In December 1948, there was a 69-year-old gentleman who consulted his physician because of a pain in his upper abdomen. And he had suffered this abdominal pain for some time. The patient was a pipe smoker. He was somewhat overweight. The rest of his history was non-contributory, but the physician who did the physical exam noticed that he had a pulsating mass deep in the center of his abdomen. So So we'll go back to that later. What is the big deal with aortic aneurysms? It's present in upwards of 8% of males over the age of 65. It's the 14th leading cause of death in the United States and 4th in males greater than the age of 70. Ruptured abdominal aortic aneurysms causes between 4 and 5% of sudden deaths in the United States. We think that a lot of patients never even make it to the hospital with these. The 5-year rupture rate of those that are incidentally diagnosed in population-based samples of greater than 5 centimeter aneurysms is between 25 and 40%. It's huge. And the fatality rate when we have to do emergency surgery on these patients is huge, 50%. So we estimate that 75% of patients die before ever reaching the hospital if they present with a ruptured abdominal aortic aneurysm. Of those 25% that reach the hospital, upwards of 50% of the patients die before reaching the OR. So really the number of patients that succumb to this disease once it ruptures is huge. So it's very important to diagnose these. Now, a little bit of anatomy lesson. This is the aorta, and obviously it comes off the heart right here. Ascending aortic aneurysms typically are not treated by vascular surgeons. Those are treated by cardiothoracic surgeons because you have to put the patient on a pump in order to treat those. But we, as vascular surgeons, treat essentially everything from here on down. Sometimes we have to do bypasses to keep blood flow to these vessels when we do fix them. And sometimes now we can actually put holes in our grafts with lasers. I know it sounds pretty modern, and keep blood flow to these other arteries while excluding the aneurysms with endovascular grafts. But most of the aneurysms that we see are infrarenal abdominal aortic aneurysms. And when we say infrarenal, that means below the renal arteries. It's important that we look at the diameter of the vessel below the renal arteries because that kind of determines on how we're going to treat them. But normal aortic diameter is around 2 centimeters throughout the entirety of the vessel. Up in the aortic arch, it's more about 2.5 centimeters. So how do you find the aneurysms? High index of clinical suspicion, clinical suspicion, clinical suspicion. We talked about this earlier. Thorough routine physical examination. On a thin patient, it's not uncommon that you should be able to feel their aorta and feel if they have an aneurysm. If they have unexplained back, abdominal, or pelvic pain, especially with a history of smoking or family history, it's important to look for aneurysms. Patients, male gender, greater age, high blood pressure, history of coronary artery disease, family history of abdominal aortic aneurysm, tremendously important. High cholesterol, PAD, carotid disease, smoking, high BMI, all of these have higher incidence of having an abdominal aortic aneurysm. And the prevalence of those with an aneurysm that's greater than 3 centimeters in nature in those who've smoked and those who are greater than 60 or 70 is huge. The prevalence is fairly negligible for those under 60. The only people we see with aneurysms under the age of 60 typically have some sort of degenerative tissue disorder. We do look at males predominantly, although we do see them sometimes in females. A VA study saw that the incidence was about 4.3% in men and 1% of women. And as we said earlier, a family history is tremendously important. So Medicare and the U.S. Preventative Services Task Force realize how important this is. And Medicare actually pays for one-time screening with ultrasonography in men ages 65 to 75 who have ever smoked anything at all, even just one cigarette. It's no risk, no radiation, but it's a good screening tool, and it should be done on all your patients who've ever smoked. Men and women, the Society for Vascular Surgery came up with guidelines that recommends that same screening for men and women who have a history of tobacco use. And first-degree relatives of those with abdominal aortic aneurysm should also be screened as well. So again, we go back to Medicare guidelines recommend a ultrasound in those between the ages of 65 and 75 who've smoked at least 100 cigarettes in their lifetime or with a family history of abdominal aortic aneurysm. Abdominal aortic ultrasounds actually have a very high sensitivity and specificity for picking up these aneurysms. A CT will almost always get a CAT scan prior to fixing these if we identify them with ultrasound, but an ultrasound is a fantastic screening tool that's probably underutilized. So how do these patients present? They present with abdominal flank pain, pulsatile abdominal mass, incidental finding on radiography. Sometimes we'll see them after they're getting lumbar films and they're picked up on lumbar films, or workup for other arterial disease. Who do we fix? Those greater than 5 to 5.5 centimeters are those that we recommend fixing. Studies have been shown that those less than that, the risk is higher to repair them versus not repairing them. Their overall mortality risk. We do sometimes fix saccular aneurysms earlier. If a patient has a focal outpouching like this right here, we do think those have a higher incidence of rupturing, and so we'll be more aggressive about fixing those smaller aneurysms. Of course, patients who are symptomatic with painful aneurysms, we think those have a higher risk of rupturing as well as those that rapidly enlarge. How can you maximize their treatment therapy? Blood pressure control, antiplatelet, statin therapy, EKG, coronary revascularization, all the things that you would do for most of your vascular patients, we want you to do for these AAA patients. And of course, smoking cessation, not to be a dead horse. But statin therapy is tremendously important for these patients. Preoperative and postoperative initiation of statin therapy significantly improved 1 and 5-year mortalities in those who underwent an endovascular aortic aneurysm repair. So all patients with PAD, and especially those with abdominal aortic aneurysms, it's probably secondary to their anti-inflammatory properties, but should have statin therapy. So back to that case presentation that we talked about earlier, Dr. Rudolf Nissen was the physician who identified that aneurysm in that 65-year-old gentleman. He found a grapefruit size abdominal aortic aneurysm in that gentleman, and at that point in time, they used to do an open incision and wrapped the aneurysm with cellophane. It actually kept this gentleman alive for 4 or 5 more years until he developed abdominal pain and he ended up dying. Subsequently, it was ruptured abdominal aortic aneurysm, but they actually prolonged his life for 5 or 6 years by doing that procedure. Classically, the first repairs of an abdominal aortic aneurysm were done in open fashion with a homograft, first described in 1952, and then they started using a mesh or a fabric in 1954. And nowadays, with an open operation for an open aneurysm repair, the mortality is between 1 and 5% in different series. We essentially push the intestines out of the way and expose the aorta kind of in this fashion. And then what we do is we actually clamp the aorta and sew into a relatively healthy portion of the aorta, and distally typically sew into the iliacs or a distal portion of the aorta that's relatively healthy as well, with a graft classically made of Dacron, or sometimes we use Gore-Tex. This is a cadaver a graft that we used for a patient with an infected aorta, but sometimes we do these in patients who had previous aortic surgery or have an infected aorta. We'll use cadaver graft. This is an aortic debranching. This fabric here is Dacron. This is where we were actually coming from the iliacs to reperfuse mesenteric branches to keep perfusion, mesenteric and renal branches to keep perfusion going to these blood vessels. And then we actually covered the inside of the aneurysm, as it was a fairly extensive aneurysm, with an endograft. Back in 1990, Dr. Perotti actually performed the first endovascular aortic aneurysm repair on the president of Buenos Aires. He actually constructed his own endograft, but an endovascular aortic aneurysm, we actually bring up grafts from both legs and put in a giant stent, classically covered with Gore-Tex or sometimes with Dacron, and the flow goes through the stent graft and excludes the aneurysm itself. We do these in our hybrid operating rooms with fluoroscopic capability, and the graft material and the delivery devices have improved markedly over time. They have a very low overall mortality, perioperative mortality of about 1%, if not less. They have a very short hospital stay. They go home almost the next day typically, and very quick return to full function as opposed to a prolonged ICU stay. We do bilateral femoral access, typically perform an aortogram and then place the main body and then capture the contralateral gate. This is the contralateral gate coming from the patient's left-hand side, and extend the second piece down to here. And so classically with a lot of these endografts, we do 2 pieces. There are multiple brands that we use: Cook, Gore, Medtronic, Endologix, Cordis. This is a fairly complex aneurysm. You can see the renal arteries here. The saccular component of this aneurysm is right here, and we deliver an endograft just below it to take the pressure off that wall and put the flow into the graft here. This is another abdominal aortic aneurysm that is extremely tortuous. As you can see, there's flow through the stent graft at the end of it. So another case presentation, a 68-year-old gentleman who was followed for vascular surgery for 2 years. In 2011, he presented in follow-up for bilateral lower extremity pain from his knees to his feet, first on the right and the left, has extensive past medical history. His aneurysm, he had significant peripheral arterial disease, but an incidentally noted 4.1 centimeter abdominal aortic aneurysm was noted on duplex ultrasonography. This increased in size to 4.6 centimeters by March 2012, and he had bilateral common iliac artery aneurysms as well. This is his CT. You can see the aneurysm, the infrarenal abdominal component, and these are the iliac arteries. This is the right, and this is the left. So we can treat all this with an endovascular stent graft deployment here. This is below the renal arteries, and the graft is successfully deployed to both iliacs, excluding the aortic aneurysm and the iliac aneurysms as well. So the risks of rupture, why do we fix these? The risk of rupture, greater than 5.5 centimeters can face a fairly high risk of rupture. Patients are currently smoking, if their blood pressure is out of control, if the aneurysm has expanded significantly greater than 0.5 centimeters in a year. Those with female gender actually have a higher incidence of rupture and severe COPD. So the risk of rupture in 1 year in patients with an aneurysm greater than 6 centimeters is between 10 and 20%, and greater than 7 centimeters is upwards of 33% or more. The rupture is due to a loss of wall integrity. They present with severe abdominal pain or syncope, sometimes back pain, and again, more than 50% of those die prior to presentation. And so if the emergency physician or provider has a high index of suspicion, a CT scan is almost vital in caring for these patients. It kind of determines how we're going to go about the course, and alerting a vascular team as soon as possible is necessary. We want to, call a vascular physician as soon as possible if you have a high index of suspicion. Permissive hypotension, as in trauma, is okay. Keep their blood pressure between 70 and 90 and transfer the patient and their images as soon as possible. We can go in endovascularly and put up a balloon up above the ruptured aneurysm to sort of occlude and kind of control the flow, rather than doing a big midline incision and putting a clamp on the aorta, and give anesthesia a chance to resuscitate the patient. We can do this before the patient even goes to sleep. Oftentimes, if you put a patient to sleep and they've got a ruptured aneurysm, they have a loss of systemic vascular resistance and they die on the table. Don't ask me how I know that. Doing CPR on a patient preoperatively is not a good idea. This is a ruptured open aneurysm, and this is a repair with a Dacron, open Dacron tube graft. So, why are we so worried about this? Their mortality is huge. If they have more than 2 of these risk factors, age greater than 76, presenting systolic blood pressure low, pH is low of less than 7.2, their overall mortality after a ruptured aneurysm is upwards of 70%. And if they have all 4 of these, their chance of survival is dismal. After an open repair, you can get renal failure, respiratory failure, colonic ischemia. That's why we try and do as many of these as we possibly can in the endovascular suite. This is another rupture that presented, this was fixed with an endovascular stent graft as you can see in the upper right. With the endovascular repair, the mortality is significantly lower, and we can treat upwards of 90 to 100% of these with an endovascular fashion. So with that, we'll continue the discussion for the day. Thanks so much for your attention. I hope you had more fun than my kids did on their fall break.
So the next topic is mesenteric insufficiency, signs, symptoms, and treatment. To introduce the topic, atherosclerotic disease of the mesenteric arteries, which supply the abdominal contents, affect almost 20% of those patients over 65. However, not all patients are symptomatic, but when they do become symptomatic, it can be a chronic condition that has a delay in diagnosis. This talk will be limited to chronic symptoms and treatment. There are a handful of patients that have acute mesenteric ischemia, sometimes younger due to potentially embolic disease, but we're going to talk specifically about patients with chronic mesenteric ischemia, usually due to atherosclerosis. There is a rising incidence and prevalence of this, and optimal management includes early detection and revascularization of the mesenteric vessels. As one would think, the traditional risk factors also apply to these patients, and they usually have atherosclerotic disease throughout their entire body. These patients usually manifest disease in other beds, and these patients tend to be active smokers. So the hallmarks of symptoms are the classic postprandial abdominal pain. So after a patient eats 15 to 20 minutes, they get severe abdominal pain due to the insufficiency of the vasodilation of the mesenteric vessels to be able to process that food bolus. Usually over time, their symptoms become more frequent and severe. This changes the way the patient eats. They usually lose weight. Patients usually lose, on average, almost 30 pounds before they get treatment. And about 75% can have an abdominal bruit when you listen to their abdomen with a stethoscope. To just briefly talk about anatomy, three main vessels, the celiac, SMA, and IMA. This vasculature has a very robust collateral system. SMA and celiac communicate via the pancreatico-duodenal arteries. The SMA and IMA can also communicate via the arc of Roland and the artery of Drummond. And usually a patient has occlusion or significant stenosis, at least two of these vessels, if not all three, for them to create symptoms. Sometimes they can have an isolated lesion of the SMA, but it is usually the SMA if it's only one vessel that's diseased. So the diagnosis is usually made by duplex ultrasonography. This can record the degree of stenosis in the SMA, IMA, and celiac, and this is usually recorded as an increased velocity and how fast the blood is moving through those vessels. Some labs have different criteria for the velocity cutoff. Usually in the celiac and SMA, 200 centimeters per second denotes a greater than 70% stenosis, and in the SMA, slightly higher at 275 centimeters per second. Patients can also be worked with an MRA or CT scan, but usually this comes from an outside facility, and usually our first go-to is ultrasound, and if this shows a stenosis and based on the patient's symptoms, we can go straight to angiography. They can also treat at the same time. These patients have also potentially had other GI workup because they have a slight delay in diagnosis. Especially if they have atypical symptoms, they've usually had upper GI or endoscopy, but they usually don't reveal too much information for us. Females are more prevalent in females than males. Like I said, the majority of patients are over the age of 65. Almost 20% don't have the classic symptoms of postprandial abdominal pain. Sometimes they present with nausea, diarrhea, vomiting, constipation. And like I said before, there can be almost 1.5 years delay in diagnosis in some patients, especially if they're younger or not the classic vascular path that we see. As I've said before, the majority of patients have an SMA lesion that leads to symptoms. A lot of patients have 2 to 3 vessels that are involved. There are other reasons for mesenteric insufficiency besides atherosclerosis, but this is the primary one. We can have fibromuscular dysplasia and arteritis and median arcular ligament syndrome, but we're not going to discuss those topics here. So these pictures on the right, the top one is a CTA with contrast showing a lateral view of the aorta and the spine. You can see the celiac is that first branch with a high-grade stenosis, as well as the SMA showing a high-grade stenosis. The picture below is angiography showing the celiac. This is the first vessel coming off. It's widely patent, and the SMA with a very high-grade stenosis indicated by the arrow. So the old way to fix this was an open surgical bypass to the mesenteric vessels. The picture on the right shows isolation of the SMA with the yellow vessel loops above and below. The patient's head is to the top of the screen, the patient's feet are to the bottom. So the yellow vessel loops have isolated the SMA. The graft coming through or next to the IMA has already been sewn to the supraceliac aorta. This has been tunneled retropancreatically. It's going to be sewed between those vessel loops for an aorto-SMA bypass. As you can see in this picture, this patient did have a component of acute mesenteric ischemia. The small bowel in between the blades of the retractor is normal. The small bowel below, you can see, is dilated, it's congested, it's purplish, more red, and looks inflamed. This patient had an occluded SMA stent that could not be reopened, so this patient had to have a surgical open bypass, which is usually reserved for those patients refractory to stenting or re-occluding their stents, potentially have a more acute component, or those patients that can't be treated endovascularly. This does have a pretty high mortality and morbidity rate, especially if there's an acute component, but it can be a durable fix and good surgical candidates. Usually we like to treat these patients, especially if they are just chronic symptoms, endovascularly first, and these are usually because these are osteo lesions and they are treated well with short stents in the ostium. Usually we have almost over 90% success rate in treating these with stents, very low morbidity and mortality as compared to open surgical bypass. However, these stents tend to re-occlude and the re-intervention rate can be very high. Our philosophy is treating these endovascularly first, usually a stent. We diagnose these and repair these, and we reserve the open reconstruction for very complex disease patterns without endovascular options. This is a picture of an 81-year-old female with postprandial abdominal pain and weight loss. The arrows point to a 95% SMA lesion or stenosis that was treated with a stent. The top picture to the left corner is the diagnostic angiogram. Second, we pre-dilate these with the balloon in order to get our balloon-mounted stent through the lesion, and then completion would be the bottom right picture treating that osteo lesion. The next patient is a 67-year-old male with nausea and vomiting and early satiety, and this is a 95% celiac stenosis treated with a balloon-mounted stent as well, with good result. So in conclusion, chronic mesenteric insufficiency, usually classic postprandial abdominal pain with weight loss in patients that also have other vascular disease as well. The workup usually includes ultrasound and angiography. Can be a delay in diagnosis. We usually like to treat these patients endovascularly first to include stenting of the involved vessels because these open operations or open surgical bypass are usually reserved for patients with acute or chronic symptoms or occluded stents that can't be reopened, or flush occlusions of more than 2 vessels, and patients that are good surgical candidates.
Good afternoon. We're going to round out this session talking about renal artery therapy. When to apply therapy to the renal arteries, when should we work this up? Despite continued improvements in efficacy, controversial issues surround endovascular renal care, and so we need to know when to apply this. This is a typical catheterization of the left renal artery. You can see the high-grade lesion at this point. And then this is a balloon that has a stent over top of this. And following that, we have deployment of the stent by expanding that balloon. And now we have an open renal artery, excellent flow. All of my cases look just like this, as perfect as this. But this is exactly what you want to see post-intervention. So the prime dictum is first, do no harm. And so when we talk about vascular interventional care, it's always a balance between maintenance of a problem or avoiding disasters. And disasters in this situation would be someone with a renal artery stenosis that closes, that occludes, and then now they are on permanent dialysis. Another disaster would be a hemorrhagic stroke and the complete damage of this brain. So the question is, when do we look for clues to think about renal vascular hypertension, and when should we consider, working this up for repair? So if you have a patient that has a new onset of hypertension before age 30, or significant diastolic hypertension in patients older than 55, or if you have upper abdominal bruit that's lateralized, or a patient that has accelerated hypertension or hypertension resistant to triple hypertensive medication, that's when you want to consider workup for renal vascular hypertension. Progressive renal failure with a normal SED rate, or diffuse atherosclerotic vascular disease, in heavy smokers. It's not like we don't have a lot of those patients in our clinics every day. Well, what about acute renal failure secondary to ACE inhibitors or ARB inhibitors? They can lead to a sign that there may be renal artery stenosis, or recurrent or unexplained acute pulmonary edema. This is another sign of when we need to work up a renal artery disease. So what is it made of? 90% of the time, it is related to atherosclerotic disease. It usually occurs at the renal artery orifice, and there's no specific risk factors other than the traditional for making plaque. And progression of the disease of that plaque can occur in 50% of the patients within 1 year. So you see here an MRA, and you can see a dropout zone. That same CTA shows the high-grade lesion on the left, also on the right. And now we have evidence of stenosis. That's one way to work that up. The other etiologies are fibrodysplastic disease. We've heard of FMD. There's different types of that. There's intimal fibroplasia. It's rare. It's associated with trauma. And there's medial fibrodysplasia, the most common form. Commonly, it happens in females and it tends to be right-sided. And it can be involved the distal portion of the renal artery where there's a string of beads that we see. So this is intimal hyperplasia from a traumatic injury, a stretch injury, and then a narrowing of that area. This is the traditional FMD that we typically see, that string of beads on the end of the artery that responds very well to angioplasty, and that oftentimes can be curative of hypertension in these patients. So how do we diagnose these? Well, duplex sonography allows for both anatomic and functional assessment of the stenosis. So that is my preferred method of workup. It requires a skilled sonographer. Sensitivities are high, 90%, specificity 95%. And what we're looking for is a stenosis of the renal artery greater than 180 centimeters per second with renal aortic ratios that are high, and that leads to the diagnosis of a hemodynamically significant lesion. So this is a normal renal artery. This is the aorta in transverse. This is the renal artery laid out. The kidney would be up here, and there's a normal flow pattern in that artery. Here is an artery on B mode where we don't have the flow characteristics, and we can see the string of bead effect. So we can actually see this on ultrasound. Now this is a renal artery, and you see all this speckling pattern. This is turbulence. When you listen with a stethoscope on the abdomen, you're going to hear a bruit, and that is what you're hearing. You're hearing that turbulence of blood flow through that area. So MRA is also utilized. You can avoid risk of angiography. New techniques can talk about functional significance. The sensitivities are high. The specificities are also high. You can see an MRA here showing fairly normal kidneys here, and then this showing the high-grade lesion in this proximal renal artery. So this is another way to get anatomic imaging, but not necessarily functional imaging. So interventional care percutaneous transluminal angioplasty is one of many options. Technical success does not equal clinical success. That's important. We can have high technical success, but clinical success is a whole different deal. This may result in intimal dissection or arterial thrombosis and worse renal function and/or outcomes. And so we often use a stent in the proximal renal artery to fix that. Durability can be low in bare metal stents, 25% experiencing restenosis within the year. Fortunately, some of the work by Dr. Harris and myself many years ago showed that covered stents tend to reduce that amount of restenosis. And we expect much less restenosis with a covered style stent than just a bare metal style stent. So when we do our angiogram, we can see there's a lesion to fix in a patient with poor GFR, and we're fixing this because of ischemic nephropathy. We can often use a filter that will capture any atherosclerotic debris when we do the angioplasty. And then as we open the kidney, we can remove that filter and hopefully maintain the function of that kidney. Sometimes it's a surgical correction that we need to do. The indications for surgical revascularization are failure of percutaneous techniques, or patients require replacement of the abdominal aorta. So if we do that, we would also revascularize the kidney. Severe atheromatous plaque can fall into the kidney when we're ballooning it, and so we would consider surgical revascularization or restenosis after angioplasty stent where you can't fix it. So that's when you would have to consider surgery. Surgical revascularization techniques, you're basically attaching a vein to the artery down here. This is the renal vein up this way. This is the aorta. And then we separate this, and now we have a good flow now into that renal artery. Here's another example of a kidney. This one's the normal kidney. This one's been transposed down to the iliac artery. This is the bypass, the aorto-renal artery bypass. And that's one other way to reconstruct the circulation to the kidney. So is there any data out there about telling us what to do and how to do this? Well, there was a clinical trial called the CORAL trial. This ended at around 2010. And what they basically did was they looked at about 1,000 patients, and they said, well, can we have reduced outcomes for kidney disease or reduced cardiovascular outcomes if we fix a renal artery that is relatively asymptomatic. And what they found was that the chronic kidney disease event outcomes, end-stage renal disease, or greater than 30% reduction in GFR, or death by kidney disease, that occurred in about 19% of the population of the patients. And there was really no difference between the two groups. What about cardiovascular disease event outcomes? CVA, MI, congestive failure. This occurred also in about 20-some% of patients, and again, there was no difference in the two groups. So revascularization by renal artery stenting did not significantly slow progression of chronic kidney disease or reduce CV outcomes versus maximal medical therapy in asymptomatic people. That's the key, because we treat patients who are symptomatic. So when we consider patients that are symptomatic, there's really no gold standard in how we do this. Not all lesions warrant interventions, so that's important to know. And a combination of 2 or more diagnostic methods plus clinical judgment is the best approach to decide when to treat a renal artery stenosis. The main recommendations are that if you have a hemodynamically significant renal artery stenosis, greater than 60% by duplex ultrasound, and you have uncontrolled hypertension and poor BP control on 3+ antihypertensive meds, that's when you consider fixing that renal artery. Or if you have recurrent congestive heart failure or pulmonary edema, fix the renal artery. Or if you're worried about preservation of renal function or ischemic nephropathy, if that's what you're worried about, and you have bilateral renal artery stenosis, fix the artery. Or renal artery stenosis in a solitary functioning kidney or an unstable GFR. So oftentimes I'll have my nephrology colleagues, and we're watching a patient, and we're watching them, and if their GFR starts to fall in face of that renal artery stenosis, that's when we act, and that's when we consider doing stenting. But prophylactic renal intervention should be avoided. Don't treat asymptomatic patients, treat symptomatic patients. So the bottom line is expect high technical success rates, 98%. In patients that you're treating for hypertension, especially if they're FMD, cure rates can be up to 20%, and improvement in the blood pressure management can be in 50%. Renal function improvement that can either remain stable or improve in 30 to 40% of patients. Deterioration of renal function can occur in 10 to 20% of patients, so that's a very good conversation to talk with patients about. And then distal embolic protection may prevent atheroemboli. There's some literature out there suggesting that. So this is a quick case, a 68-year-old white female with malignant hypertension greater than 200, hypertension, long-standing COPD. She has a AAA 4.3, carotid artery disease with a left carotid stenosis in the category 2 range. She's a significant smoker, 1 pack per day for 56 years. Note she's 68, so that means she started when she was 12. She has a bruit. She has elevated velocities in the renal artery, turbulence suggesting greater than 60% lesion, and an elevated creatinine. So this is her lesion. This is her aortic aneurysm. This is the critical lesion, 99%. And we can intubate that, take a picture of the kidney. The kidney is beautiful, wonderful function, very healthy appearing. Hate to sacrifice a kidney because of one lesion like this. So this is a perfect patient to prevent ischemic nephropathy by fixing that with a small balloon and stent right there. And you can see where the stent is landed. So this stent is landed right at the origin. The reason we did that is because the patient has an aneurysm. And so if we want to, one of the things I worry about is, will my intervention prevent me from fixing future problems? And so I recommend for people with aneurysmal disease, let your local vascular surgeon, they're mostly friendly, talk about this with the patient, and so that we don't jeopardize their future surgical care. We want to avoid ischemic nephropathy and people on dialysis. We want to avoid hemorrhagic stroke. And so there is reasons to treat renal arteries.